We're going to have the panelists each introduce themselves, and then we'll open up the questions.
The who?
So you want to start with Aimee?
I'm Aimee Dudley.
I'm Jack Dinon.
I'm Sophia Dinon.
I'm Michelle Dinon. Just to give you some background, because everybody went really quickly. Sophia, we've been attending conferences since 2009 with the NUCDF. And Sophia received a liver transplant. She has ASA, received a liver transplant in 2013.
George Mazariegos from Pittsburgh.
Nicholas Amu, Children's National.
Here we have a question.
Sorry, I jumped up here. I got a text that my kid was one of the hungry ones. I did have a question as far as those considering liver transplant. My kiddo has ASA, and we know that that's a systemic phenotype, so it's not quite the same decision. And I wanted to know how you would advise families looking at some of those changes, considering if some of those, mRNA infusions or some of those lipid nanoparticle treatments versus the immunosuppressants post-transplant, and kind of adding that into your decision if those therapies would become unavailable to them despite still needing continued care for quality of life.
Sorry, that last part I missed. What do you mean that those therapies not being available to them?
I guess my question is, those therapies which do impact, especially immune system-wise, if they got a liver transplant with a ASA kiddo and they would still need continued therapy in the future, would they be eligible for that type of treatment versus the liver transplant? It just helps in, the weighing the balance of that decision.
No, that's a really good question. I can't speak to the specific new gene therapy type treatments that are going to be available for ASA. I would highlight most of the time when the liver transplant's being considered in the context of, preventing issues related to hyperammonemia. I think to your point, you're absolutely right. Because ASA is a more systemic condition, it doesn't fix everything. I could potentially see. So I would imagine right now the first trials that are going to be done in ASA are likely also going to be liver focused and target hyperammonemia in that condition. But obviously there will be something later on likely to potentially target the CNS and the brain essentially. I would imagine that there are some folks who would have already had liver transplant who would potentially be eligible for those trials as well. I hope that answered your question to some extent.
I think so. I think my question was more about, does the immunosuppressant medication to defer rejection affect your eligibility in those trials?
I can speak a little bit to that. I'm not, from a transplant perspective, typically, and we work obviously in collaboration with our genetic colleagues, Dr. Lichter's here in the audience, for post-transplant care of these patients. But our immunosuppressive therapy, number one, is similar compared to all the urea cycle conditions, so it doesn't change. Number two, it does decrease significantly over time, and so our goals would be that over, by the first year or second year, you're just taking one immunosuppressant therapy. And thirdly, we're working continually to reduce the lowest level. Typically, children who are on FK5 tacrolimus do not have any increased susceptibility to any kind of bacterial or by the time they're late after transplant, other common infections. Sometimes they're healthier than some non-immunosuppressed patients. So I would defer to my genetic colleagues, but I'm not aware that being on tacrolimus would affect any further options for that child. And I'm not aware that our patients who were transplanted for ASA are taking any different therapies post-transplant than the other UCDs.
Thank you very much.
It's me again. Yeah, right. Well, so my son is about 15 months post-transplant. I went through all the stages that you described when making that decision. Initially, back home, we had no support medically, so we moved here, and we had the best, TCH, Dr. Lee, everything. Despite that, I made the decision based on family support and looking ahead that if something were to happen to me, it would be much easier for someone, that had to take over to manage a liver transplant than a UCD. That it came down to that. He was getting older, and it wasn't much about independence. It was more so about care. I will say though, for those families that are doing the transplant because they don't want to deal with insurance, it's the same thing. We're still fighting for tacrolimus some months, right? So, however, I want to talk to you about the immediate post-transplant care when you're a UCD patient. And I have asked other families, and I felt, and actually it was, we were up on a limbo. The transition from UCD to, well, now you have a liver, here's bacon. That didn't work. My son was starving for 15 days, literally starving. He could not eat anything, and the expectation from liver team was, what's your problem? You can eat everything. So I found it not only challenging as a mom, but as a care provider, watching that situation unfold and having no support, no coordination. I think the expectation, have you looked into that immediate post-transplant for the patient with the urea cycle disorder? It's not the same as a post-transplant for a liver patient. And the expectation from the liver team was like, well, look at him, he's fine. No, he's not. No, he was fine before because we're used to the managing and the counting the protein, etc. But I feel there is a void in that immediate coordination. And I wonder what's your, outlook into that, or how we can improve those situations.
I think also some of it's psychological, and because as a patient, your whole life you naturally just don't want it, and something switches. All of a sudden you're allowed, but that doesn't change your chemistry in your brain and your emotions, psychiatric things. So I think that part is probably the harder part for transplants, is that all of a sudden you're allowed, but
my son did mention, I know that my body is ready because I have a new
but you're
liver.
so
But he
conditioned.
said, my brain is not ready. But I don't know that it was emotional. He was very sick. He could not eat.
I mean, I
He was in a lot of pain. It was very, very painful. And also the feedback that I got from the liver transplant team over and over was, liver transplant doesn't hurt. I'm like, really? So that was very challenging for me. And I want to hear from because this is the UCD community, if we are looking into that, if you're receiving that feedback from the patients that are transplanted, and how we can really come with better situations for the families. Because I came in, everything was fine, I could manage everything, I had the best doctors, and then I found myself like, I have no idea what's happening. Like, what is happening? Like, what is this? And there was like, well, you're not a UCD patient anymore. Like, you have a new liver, now you're a liver. I don't feel that there's that switch that just goes off.
Where was he transplanted?
I'm sorry?
What facility was he transplanted?
Texas Children's.
Okay.
Yeah, last November 30th, 2022.
And he was a lot older, right? He's
So he was
15 or
16.
16. 16?
Yes, he was 16. I did consider this for a very, very long time. Early on, you know, Dr. Lee was like, we'll manage him, and it worked. He was stable. We went through all the trials. We did the Ravicti trial, and then Ravicti was a life-changing medicine. And so it was okay. I mean, it was fine. But I thought, no, you know.
I think you're going to find variances between the facilities that you approach for a liver transplant. We chose Pittsburgh because of their overall knowledge with both UCD and liver transplant, and we were hoping that that cross-functional team would help us manage that transition. That said, Sophia was a lot younger than your son, and I remember the day after her transplant, all she wanted to do before her transplant was eat cheese sticks. Couldn't eat cheese sticks. Yes, I'm gonna talk about this.
Yeah.
And I was so excited to go to the grocery store across the street and get an entire case of cheese sticks. I didn't get a pack, I bought the entire box.
Yeah.
When she came to and was going through recovery, there was no desire.
Nope.
None. There was none. And I think some of that's physical. They probably still don't feel that great when they're on medication. I think a lot of it's psychological. And again, Sophia was a lot younger than your son, so I think that she was able to kind of adapt as time went on, and now she eats a full diet that
Did
you
you
would
get that
consider.
case of Cheez-Its?
Yeah, lots of cheese. But that doesn't happen overnight. And I can't speak to the difference in the teams, like their reaction, like the liver team is like their liver, they're fine, or the metabolic team maybe not giving you the support that you're looking for. But I think that it's just gonna take time for your son to rewire his ability to
Oh no, he's fine now.
accept.
I mean, now life is good again. Well, he still has not. Then he developed RFID. Like he will not eat anything but what he wants to eat. But that's not the point. I'm talking that immediate post-transplant medical management. In the terms of, it is true when we talk about transition. Now, if I try to call complex care, they're like, well, he's a liver transplant. Now, I don't want to prescribe anything without running it by. That multidisciplinary or multi-specialty care, when you have that patient that you know he didn't have liver failure, his life was good, you know, you have to consider those things. So I was wondering what's the next steps for that.
Yep, I'll just speak briefly, and then maybe Nick will also have some comments. I think from a care point of view, the multidisciplinary team is very, very important to ease in that transition. So this includes our surgical team, the ICU team, but also nutrition. And even though they're cured from a protein point of view or restriction point of view, we do have our dietary nutritionists that help advise in just how to help children who aren't used to eating this diet, how to begin in that process. And my observation has been that there is a lot of variation in the children. So some are better eaters orally, some are used to just tube feedings, and we, just like with UCD or with many other metabolic conditions, we have to begin this oral feeding training process. So it takes a dedicated team that's helping them to make that process, and it's very individualized. But I think working together with a nutritionist has been helpful in Pittsburgh to help, especially younger kids, to adapt and to begin to orally feed a healthy diet.
Yeah, excuse me. I would echo everything Dr. Mazariegos has said here. I agree that it's tremendously challenging for a child that has never eaten much protein to be able to start doing that afterwards. But there's also been a huge variability. Some kids that immediately want to eat something that is high protein, and some that find it very difficult to start eating more protein. We also similarly integrate with our transplant teams to make sure that we're following up, in the post-transplant period in terms of care and in terms of diet. And so our dietitians are also involved in their ongoing management.
The UCD dietitians.
Correct, yeah.
Yeah, okay, thanks.
Yeah, it seems like that's an opportunity for us as a community to develop some more focused guidance. I think these points of transition are places where we want to make sure people are communicating and we can share best practices and have all the people who've been through it share what they learned with everyone else. You know, similarly, my sister's, I think her biggest complaint about the liver transplant was the transition to adult care, because eventually they can't stay at a pediatric institution, and that is another transition point that also can use more support.
I have two questions. Let's put this down. First is for Dr. Mazariegos. I hope I'm pronouncing that right. Probably not. So I really appreciated how in your talk you shared how you're sort of thinking about the future, looking more holistically at patient outcomes and measures like quality of life. But you know, as I'm sitting here, I have a very young daughter, and I'm sure many of us here have very young kids, and I'm looking at the 10, 20, 30-year data and thinking that's not very long, you know, for someone like me with a very young child to make a decision. So is that data, is that limited by what data exists? Is that just the cultural norm within transplant to look at like up to 3 decades back, or is there longer data, and is this something that you're thinking about? That's my first question.
Excellent question. The data that we presented is based on projected data because liver transplant is relatively an early, a young technique in some ways. So currently, I know long-term survivors personally that are 45 years post-transplant. And our first transplant in Pittsburgh in 1981 is doing well after his liver transplant. But most of the liver transplants have been done since 1991, mid-90s. And so the typical data that's presented is actually worse. So it's actually 1 and 5 year data. That's what is usually presented on the public website. So my first encouragement is that, you know, that is almost meaningless. I mean, it's obviously important that you go to a center that has a high 1-year survival, 5-year survival, but you really want to ask them about their 30, 25, or go to centers that have had lengthy experience. So however, what we do know is that as opposed to kidney transplant or heart transplant, different organ transplants do have different biologies, and so the kidney transplant is known to have a shorter, what's called a half-life, meaning that under the current situation, it is likely that a kidney recipient might need another kidney transplant sometime in their lifetime, even with good care and good follow-up. Mostly due to the biology of the kidney graft and what is known as chronic rejection. And so heart patients and kidney patients, when we care for them, we're looking at really try to optimize everything, but still understanding that with optimal care, they may still require a retransplant in some point in their life, typically 20 years or so currently. For liver transplant, that half-life has not been demonstrated. So the majority of children in the United States still are living with their primary graft. And that data that I showed from that one slide, you can see that we are not seeing a steady decrease in the long-term survival, so that it appears to be plateauing at that 80% level, and it's not winding down. Obviously, we'll need more data. The good news from our point of view here in the metabolic community is that data that I showed is aggregate for patients, all comers of all centers. So if you have a metabolic condition, you may expect that there to be even a improved parameter, whether it's 5% or some interval better, because chronic liver disease, autoimmune disease, cancer, acute liver, all those are included in there and may bring that, may have a lower, still a very good outcome, but lower than metabolic conditions. And then there's the center variation. So you have centers that may have even a higher expectation of outcome. So I think the outlook, what I tell families who are coming today is that we believe we can expect a near normal lifetime outcome based on our center's 30-year data based on the projection of the OPTN data and these biologic factors that we see.
Thank you. And my second question is for Dr. Dudley. So at the end of your talk, I think in response to one of the last questions, you were talking about the relationship between your work and what we can, think about in the human expression of these variants. I wondered if you could speak a little more to that, in particular things like lionization. Like the variant itself doesn't necessarily indicate that a severity of disease. So I wondered if you could talk about all the other factors that we want to think about that sort of mediate the relationship between the variant and the disease itself, the expression of the disease, the phenotypical expression.
Absolutely. Thanks very much for that question. So this is a really important point. So some genetic diseases are more genetically determined, and some diseases, even though they have a genetic cause, there's a mutation that sets the disease in motion and that somewhat affects the severity. They have a significant environmental component. And so as you all are aware, urea cycle disorders have a strong environmental component, right? Your diet, whether or not you happen to get the flu and medications that you might be prescribed. And so there is that component, which is variable, and that we know in terms of, there are some drugs that are contraindicated, right, that would be really dangerous to take. But the full extent of this environmental variability is not completely understood, so that, we can't say, all right, here's exactly what you will see, what you and the doctors will see, when somebody gets the flu, right? And so one of the real advantages, one of the real valuable contributions of our work is we take all of that out when we put a human gene and a human genetic variant into a yeast cell, because we grow those, so those yeast cells all have the same genetic background, right? So there are other genetic factors, right? We have other variants in our genome that might make us do better than you would expect or worse than you would expect, so we call those genetic modifiers. We take the environment out of it, so our yeast cells are grown, they stay at the same temperature, they stay on the same food sources. We set it up so that they all have equal access to a constant food source. We can't do that with people, right? And we can't do it with mice even, right? And so what this allows us to do, to the extent that the yeast physiology matches the human physiology, is to be able to say, here's what you would expect genetically. And so now when somebody does better or worse than you expect based on that physiology, now that's a real opportunity to be able to learn more about the disease, right? So there are individuals with some genetic mutations in their background that they do not get, for example, HIV, because they have a modifier in their genes that literally does not let them get infected with the virus. And so there are individuals who have, these strong loss of function mutation, these very, very low activity that aren't diagnosed until they're 69 years old, and in some cases that's only through cascade testing because they had a family member. So what's different about these individuals that is protecting them from what should be severe disease, and can we learn from these individuals in a way that could help us, in the HIV case with this gene called CCR5, it led to the development of new drugs and gene therapies. So this can be really valuable.
I just wanted to say, and this is hypothetical, we put this session together so that it could demonstrate with Dr. Dudley's science, you can get information. Then with Dr. Aimee's decision-making, you can better make a decision. And then to have the option of the work that Dr. Mazariegos is doing. So we put this together so that it makes it the process of making that decision is there. And then with the Dinons, their decision. Every family has a different decision. And if we could go back in time, if I could go back 20 years with the science of today, I would have made a different decision. And you would have done something different as well. But because we are where we are, we have tools. And 10 years from now, those tools will allow us to make even better decisions because the science is there, the technology is there, the support is there. So I just wanted to kind of illustrate that's why we put this whole session together. Okay, that was it.
Hi. I have a question about medicine in particular. My brother had ASA. He transplanted 15 months ago. My mom was here earlier. A specific question that I have is when he was first diagnosed, he was taking one medicine, then things developed, then he started taking Ravicti. Now he got a liver transplant. He's on Tacro. Is there anything that is telling you guys right now, and correct me if I'm wrong, but I heard that you guys are still developing some statistics on liver transplants on ASA patients, kind of that data being different from a regular patient just needing a liver transplant. Is there anything that's telling you guys right now that specifically for ASA patients that got a liver transplant, that we might have to develop a new drug for him to take specifically because he had ASA as opposed to a regular liver transplant person?
So I think we talked a little bit before about how ASA is as a result of an enzyme defect that's all throughout the body. So insofar as ammonia control is concerned, it would appear from all the work that has been done, it shows that ammonia levels are completely controlled as a result of the liver transplant. We do know, though, that there is this defect in this ASL gene that's in other parts of the body, including the brain. And so that's something, obviously, that's not corrected through liver transplant. And so there may be in the future additional therapies that would better target that.
Okay.
And just to focus, as far as we know right now, there is no additional drug that needs to be treated for ASA. There's really not because of the effectiveness of tacrolimus in general, that and the ability to wean it over time, we don't anticipate that ASA patients need to be treated from an immunosuppressant point of view any different way as other urea cycles. So that is not my experience, that we treat them the same way. And we don't anticipate needing to develop anything new. The results from a liver point of view should be equally as good, and it shouldn't impact their ability to get some other intervention in the future.
Thank you.
Hi. I think this question maybe is more for Aimee Dudley, but perhaps the other physicians. It's great that there's this model and there's more opportunities to study the different mutations. And also you mentioned the genetic modifiers. And we know that different people present differently even within the same mutation, so there's so much variability. I'm curious to know what you think the future looks like in terms of precision medicine, like what are the opportunities, what are the barriers, and I think just to kind of provide a bit of a personal context, I have a 19-month-old with OTC deficiency, and I've learned through this past year and a half that his mutation, not only the condition is rare, but his mutation is super, super rare. I think only 10 people in the world are impacted by it. And then there's all this, and I've met another family who has the same mutation, and their child presented differently. So I think my vision for my son, but also for this community, is actually that precision medicine, because every individual is different. So what are your thoughts about that, and what does the future hold?
Yeah, thanks for that question. So, just some thoughts, and then I'll maybe pass it along to some of the other panelists. So of course, as we all know, one real issue with a rare disease and rare variants within rare diseases is that, your son shows up and, this may be a mutation that no one's ever seen before. What should we expect, right? And so with respect to our data, one of the things that that can be informative for is, you know, if this is a variant that an established assay that has good agreement between, and so this is really critically important, right? Convincing yourself first as a lab and others in the field through peer review that this assay is a good indicator of what we can expect the enzyme, for example, to how well we expect the enzyme to function in a human system. That's the first step. And so once we have a reliable assay with respect to that, now we can say, okay, this variant has 0 activity, right? So that's one, that's one result. This enzyme has 70% activity. Those could be two very different pieces of information that you could weigh. And our assays don't depend on ever having seen a single patient with a particular variant. So, of course, it's even better if there have been multiple patients with, your particular variant, because you could have information about how well we expect that enzyme to work, as well as how well do other patients with this particular variant respond. So you had another question.
Oh no, your response prompted further maybe elaboration. I just wanted to say that there was an article that came out that I think was a huge game changer for me as a parent, like navigating this crazy world of rare disease and just, keeping my son alive every day and fearing the worst, hoping for the best. So there was an article that came out in 2022, I believe in November, that was actually part of the consortium work, I think, but it's based in Germany, or I think most of the authors, and it was looking at 75 variants within the OTC gene, so I'm sure you know about that article. And I was in the phase at that point where I was just trying to find information, talking to other families and researching myself. And sure enough, I came across his mutation there. And it was saying that it has more than 20%.
Sorry, it has more than?
More than 20% enzymatic activity. And he's an early onset. He got sick at day 4, diagnosed day 5. So just consolidating all that information too, but I just wanted to add that context that it showed that he had 20%, or like individuals with that mutation had 20%, which is maybe more expected for OTC or patients with OTC who are perhaps diagnosed later on.
So
potentially,
yeah,
right?
Yes.
Because there's partial enzymatic activity.
So all model systems, so yeast is a model system, and cell culture, which is what this German group used, where you take modified human cells. So these are cells that they're basically cancer cells in a dish, and so they're modified human cells, but they are human. All of these model systems, they have advantages and they have limitations. And so yeast cells have advantages. Some of the advantages for this particular enzyme are that yeast has this enzyme and it functions in a very similar pathway, and you are assaying. Yes, it's the human enzyme that you're putting into yeast, but it is in the context of how that organism normally works, except that it's a slightly varied OTC. It has limitations in that there is, for example, a loop of the protein that we have 13 amino acid stretch of this protein that was not that we identified, and we found that there was not good agreement in that discrete part of the protein between human and our yeast results and human results. And so we specifically called that out and said, if you have a variant in this loop of the protein, you should not use our yeast data because we don't believe our yeast data agrees. So there are limitations to the yeast data. There are also limitations to human cell culture data. So just because a cell line is human does not necessarily mean it's the best. They're good because they have many of the other human proteins that function, but not all of those human proteins are expressed in every tissue culture cell type in a dish. And so there are issues with kind of how one goes about introducing variants into human cell lines, which are important to consider. And so there could be agreements between the yeast data and this particular study and how they needed to do those experiments. And there are technical limitations that are really quite important to consider if we're going to say, all right, what is the exact amount of that enzyme?
Well, I mean, so just to add to what Aimee shared, again, there's limitations to any system that we're using. And so Jill had mentioned the American College of Medical Genetics and some of their efforts, but what we're trying to do there is to be able to take all of these different types of inputs, not only from functional studies, but from kind of like computer-generated algorithms, existing clinical information, et cetera, to better give us information about the effects of each particular mutation. But with regard to precision medicine, these are things that we're also thinking about. Obviously there are other factors other than just the mutation that may impact on a patient's life, the likelihood of hyperammonemia and that type of thing. And Aimee and I, as well as Andrew Grubman, had recently put in a grant specifically related to triggers in OTC. To other factors, like other triggers that can precipitate hyperammonemia and OTC deficiency. So it is something we're thinking about and looking to research.
Okay, we're going to have one last question, and then we're going to break for lunch. So.
I have two quick questions, if I can do the second. My first is for Sophia. I'd like to know, how did you and your family come to the decision to have a liver transplant?
She's passing that one off because she was still a little young at that time. So she was just turning 5 when she had her liver transplant. So she remembers some of it, but definitely not the decision-making process. So she had a fair amount of hospitalizations and hyperammonemic episodes, not an overwhelming number, but we were definitely in and out of the hospital. Early in the year in 2013, she had one episode that we could not pinpoint the cause for, and that caused a lot of, we were just concerned with that. We worked very closely with our friend Dr. Barry here, who spent long hours on the phone with us, just like Cindy Lamont did during this process. But a couple of things happened during that time. So she had that hyperammonemic episode. Then we started watching her liver enzymes closer, and they were very elevated, and they weren't coming back down like they typically would have in the past after being sick. Also, her liver was always enlarged, but on scans, it started to appear that her spleen was also enlarged, which later we found out was just because her liver was so big, it was pushing everything else out of the way. So we just continued to watch those things in the beginning of 2013, and Dr. Barry, along with myself and my husband, started having the conversation about whether or not this is something that we should consider. And if we had had Dr. Amue's slides 10 years ago, I think it would have been much easier. It would have consolidated the conversations that Dr. Barry and I had over the months about making that decision, just having that all, because we considered every single one of those pieces in a very unorganized way. And if we had had everything in front of us, that the changes in the past 10 years have been amazing in terms of resources for the families.
Thank you. I have one more question, and that's kind of a follow-up to what Anna was asking and what you just said. I have a 3.5-year-old granddaughter who has OTC, and she's relatively stable right now. And so do you think that being unstable, that people should wait? Is a liver transplant something you should not rush to do if the child while the child is stable, especially that young, 3.5?
Just very briefly, I think from a technical point of view, I would ask two questions. One is, center expertise and their experience. From a general data point of view, most of the data supports that after age 1, the technical complications are fairly have been resolved in liver transplants. So when we're talking about someone who is 2 or 3 or 4. In the pediatric liver transplant expert center world, those would not be considered to be very, very young. It's more the infants under age 1, the neonates that we consider very, very young. So I think once you're above age 2, you really can take out, at an experience center, you can focus on the other decision-making time points, in my opinion, and to help with the decision.
I just want to be careful here not to give direct medical advice here, but as you heard, there's so many different inputs that go into that process, even from a medical point of view. So it'd be worth kind of exploring with your grandchild's metabolic physician and the transplant, whatever transplant options are available. I think those are all inputs into that decision ultimately.
Thank you.
All right, a huge thank you to our panelists. It is time for lunch. So as I said, this Riso restaurant is up the escalators toward the doors on your left, and we'll see you back here at 1. Thank you.